Hello, topic for today's discussion is about Achondroplasia Group. Heterozygous mutations of genes encoding fibroblast growth factor receptor 3 and parathyroid hormone receptor 1 results in disorders involving transmembrane receptors. The mutations causes the receptor to become activated in the absence of physiologic ligands, which accentuates normal receptor function of negatively regulating bone growth. The mutations act by gain of negative function. In the fibroblast growth factor receptor 3 mutations group, in which the clinical phenotype ranges from severe to mild, the severity appears to correlate with the extent to which the receptor is activated. Achondroplasia is the most common form of skeletal dysplasia, occurring in about 1 in every 40,000 births. Most of the time, people ask a question, is there a difference between dwarfism and achondroplasia? Yes, there is a difference between dwarfism and achondroplasia. Achondroplasia is a bone growth disorder that causes disproportionate dwarfism. It is a part of dwarfism, which is due to bone growth disorder. And the dwarfism is defined as a condition of short stature of any cause as an adult. People with achondroplasia are short in stature with normal sized torso and short limbs, and it is the most common type of disproportionate dwarfism. So dwarfism is part of achondroplasia as part of dwarfism, which is due to bone growth disorder and it is characterized by disproportionate dwarfism. Individuals with achondroplasia have short stature caused by rhizomelic shortening of the limbs. The achondroplasia group represents a substantial percentage of patients with chondrodysplasia, and there are three types: thanatophoric dysplasia, which is the most common lethal chondrodysplasia, and achondroplasia, which is the most non-lethal chondrodysplasia, and hypochondroplasia. All three have mutation in a small number of locations in the fibroblast growth factor receptor 3 gene, and there is a strong correlation between the mutation site and the clinical phenotypes. To start from the first one, thanatophoric dysplasia, and thanatophoric dysplasia manifests before or at birth immediately, and ultrasonographic examination in mid-gestation or later reveals a large head and very short limbs, and the pregnancy is often accompanied by polyhydramnios and a premature delivery. Very short limbs, short neck, long narrow thorax, and a large head with mid-facial hypoplasia dominates the clinical phenotype at birth. If the affected fetus survives throughout the pregnancy, the newborn will have severe respiratory distress because of their small thorax. Although this distress can be triggered by intense respiratory care, the long-term prognosis is poor. The second one is achondroplasia, which is the most common type of chondrodysplasia, and it is a prototype chondrodysplasia, and it typically manifests at birth with short limbs, a long narrow trunk, and a large head with mid-facial hypoplasia and prominent forehead. The limb shortening is greatest in the proximal segment or rhizomelic, and the fingers often display trident configuration. Most joints are hyperextensible, but extension is restricted at the elbow. A thoracolumbar gibbous is often found, and birth length might be slightly less than normal. When we see the diagnosis of achondroplasia, which is the most common type of chondrodysplasia, skeletal radiographs confirm the diagnosis, and on skeletal radiographs, the calvareal bones are large, whereas the cranial base and the facial bones are small. The vertebral pedicles are short throughout the spine, and the interpedicular distance, which normally increases from the first to the fifth lumbar vertebrae in normal population, decreases in the achondroplasia group. The iliac bones are short and round, and the acetabular roofs are flat. The tuberal bones are short with mildly irregular and flared metaphyses. The fibula is disproportionately long compared with the tibia, which is often bowed. When we see the clinical manifestation of achondroplasia, infants usually exhibit delayed motor milestones, often not walking until about 2 years of age, and this is because of hypotonia and mechanical difficulty balancing the large head on a normal sized trunk and the short extremities. And intelligence is normal unless CNS complications develop. As the child begins to walk, the gibbous usually gives way to an exaggerated lumbar lordosis. So as you see on an image, macrocephaly, frontal bossing, mid-face hypoplasia, rhizomelia or shortened limbs, especially proximal one, and trident hand, and bowing of tibia seen. Virtually all infants and the children with achondroplasia have large heads, although only fraction have true hydrocephalus. Head circumference should be carefully monitored using standards developed for achondroplasia. The spinal canal is stenotic and the spinal cord compression can occur at the foramen magnum and in the lumbar spine. The stenosis at foramen magnum is more common during childhood and it might be associated with hypotonia, failure to thrive, quadriparesis, central and obstructive apnea, and sudden death. Surgical correction might be required for severe stenosis. Whereas lumbar stenosis usually does not occur until early adulthood, unlike that of the foramen magnum stenosis. And the symptoms of lumbar spinal stenosis include paresthesia, numbness, and claudication in the legs. Loss of bladder and bowel control may be a late complication. Other common problems include bowing of legs, dental crowding, articulation difficulties, obesity, frequent episodes of otitis media, which can contribute to hearing loss. Infants and the children with achondroplasia progressively fall below normal standards for length and height. They can be plotted against standards established for achondroplasia populations only. Adult heights typically are 180 to 145 cm for men and 112 to 136 cm for women. Surgical limb lengthening and human growth hormone treatment have been used to increase height, but is not as such effective. And also C-type natriuretic peptide may stimulate bone growth in achondroplasia in animal population, but it's not used currently for human being. The third one is hypochondroplasia. Hypochondroplasia resembles achondroplasia but is milder, and usually it's not apparent until childhood, when mild short stature affecting the limbs become evident, and the children have stocky build and a slight frontal bossing of the head. And the learning disabilities might be more common in this condition. Radiographic changes are mild and constant with the mild achondroplasic phenotype. And the complications are rare in hypochondroplasia, and in some patients the condition is never diagnosed at all. Adult age for this group is slightly better, and it can range from 160 to 146 cm. When we see the treatment of achondroplasia group, recombinant growth hormone therapy may enhance growth and improve body disproportion, and there is no cure for achondroplasia group at all, and the management of achondroplasia is treating the complication. The most common complication is obstructive sleep apnea. For such patients, losing excess weight, CPAP to keep the airway open during sleep, and adenotonsillectomy is very important. And also the other most common one is middle ear dysfunction with hearing loss, which can sometimes affect language development. For those groups, using ear tubes which allow air into the middle ear will prevent fluid buildup. And the other is hydrocephalus. Only fewer than 5% of people with achondroplasia develop hydrocephalus, and if they develop hydrocephalus, shunt insertion is needed. This is all about achondroplasia group. Thank you for watching.